All right, it's 8:01. We'll go ahead and get started. Good morning, everyone. We have 3 speakers this morning for Nephrology Grand Rounds. Launching our morning will be Dr. Lauren Ring, followed by Dr. Abal Kerala, and then we have a visiting speaker from the Division of Allergy and Infectious Diseases, Dr. Carol Baumstick, who many of you likely know, who will wrap up the morning. So without further ado, Dr. Ring.
All right, great, thank you. So I'm just pulling up my slides right now. So it's really my honor and pleasure to get to talk to you guys today about weight management and chronic kidney disease. This is something that I've become interested in over the past year. I do have a disclosure to make, which is that my partner is a bariatric surgeon at Virginia Mason. But my real interest in this case has really been inspired by the patients that I've seen in clinic over at Harborview. And in particular, I have one patient that really represents some of the struggles that our patients face. So I have a young woman, Miss B. She's a 22-year-old woman with a long-standing history of lupus nephritis, who unfortunately, without getting too into the details, was hospitalized in April of 2021 with severe COVID pneumonia and was started on dialysis at that time. She was initially started on hemodialysis, but when I saw her transitioned over to PD in July. She's overall doing really well on PD, and she's very interested in transplant. She has multiple family members that are interested in being living donors, but she unfortunately cannot get a transplant until she loses weight. So just reviewing some of her data, you can really see that her vital signs are most significant just for an elevated weight. Her blood pressures have been under control. She's on a standard cocktail of chronic kidney disease medications. The Auryxia is an iron-based phosphate binder. She's also on hydroxychloroquine and prednisone for her lupus. As far as her PD prescription, so she's just on nocturnal PD. She does 8 hours, 4 exchanges, and only has to use the 1.5% dextrose. Her labs, as you can see there, really show that she's got great adequacy, and her residual renal function is pretty significant, so it accounts for about half of that. So she comes to see me, and she's really trying to lose weight. She's been exercising, multiple times a week, going to the gym. She's watching what she's eating, but unfortunately, she's just very frustrated. She asks me, what can she do? And so the purpose of my talk is really to try to help us understand, what can we tell her? And so the objective is just that we can describe the trends of obesity and the relationship between obesity and chronic kidney disease. Just to look at the evidence supporting lifestyle interventions, including diet, physical activity, and how that affects weight management. To look at some of the pharmacologic treatments that are available, and then finally to discuss bariatric surgery. So I don't think this is new information for anybody in this room, but obesity has been a growing problem both in the United States and worldwide for decades. And so many of you may be familiar with the figure here on the left, which is the CDC heat map. As you can see, the colors correspond to the percentage of the population in each state that would qualify as obese with a BMI greater than 30. And some of you might be looking at Washington saying, woohoo, we're yellow, we're doing better than our southern states. And certainly that may be true, but when you look at the trends over time here on the right, you can see that Washington, just like the rest of the states, is really not beating the battle of the bulge. And we also are having increased rates of obesity. So if that were not enough, along came COVID. And, there are certainly reports that obesity trends are becoming, have been worsened by the COVID epidemic, particularly in the early lockdown when when people were being less active and living more sedentary lifestyle. But, what does this mean for kidney patients? And so, this was a really interesting study that I found of the NHANES study, which basically describes trends in the United States population. And this right here, this graph basically shows the proportion of patients who have CKD who are classified with obese over time. And so unfortunately, the most recent data here is from 2011, 2014. But what you can see is that, so this bottom gray here is patients whose BMI would be 30 to 35. This middle one is 35 to 40. This greater one is 40 and above. And what you can see is that about 44% of patients with chronic kidney disease are have obesity, and half of them are considered to have severe obesity. And just in comparison, at the same time, patients without CKD, the rate of obesity was about 36%. So again, it's an enriched population that we're seeing with this problem. So, I really put this slide to acknowledge that there are many different ways to classify obesity in patients. And unfortunately, we don't have enough time to talk about the specifics of each of the different mechanisms, but I do want to take a moment just to talk about BMI, because this is what we will most commonly use to classify patients as obese, both in clinical practice and in research studies. And I think the reason why we use it is pretty obvious, right? It's, the data is pretty easy to get. All you need is the weight and then the height in a patient. And you can put those two numbers together and calculate out of obesity and put them into kind of one of these categories, whether they're underweight, normal weight, overweight, and obese. On a population-based level, obesity and BMI is associated with cardiovascular and metabolic outcomes. However, you can imagine that for an individual patient, a BMI may not be as accurate. And so, for example, you can have two patients who have the same BMI, one patient who is fit and exercises, very muscular, another patient who is sarcopenic and has a significant amount of visceral adiposity. These are two very different patients, and BMI does not necessarily capture that. But, I think one of the things that we wonder about is, here we've just talked about different classifications and different numbers that associate with BMI, but, I don't want to just focus on the numbers. I want to focus on why it matters. And again, I think that most of us are familiar that obesity has a wide range of effects on almost every body system, in almost every body system. And, this is nephrology grand rounds, not general grand rounds. So I think it's important to focus on some of the effects that obesity has on the kidney. And so, here's just a few different things that have been observed with obesity. Certainly patients who are obese have a higher risk of developing nephrolithiasis. There's an increased risk of kidney cancer. So there was a study out of the United Kingdom which found that for every 5 kilograms per meter square increase in BMI, there was a 25% increase in the risk of kidney cancer. Of course, and they postulate that 10% of all kidney cancers are related to excess weight. Certainly, obesity increases the risk of hypertension and diabetes, which we are familiar as being major contributors to CKD. And then finally, there have been associations between increased BMI and the risk of developing end-stage kidney disease. So there was a Kaiser observational study of around 300,000 adults, which basically found that patients with a BMI of 30 to 35 had a 160% increased risk of developing end-stage kidney disease compared to normal weight. And those who were greater than 35% had a 400 to 500% increased risk of developing end-stage kidney disease. So, we don't have as much time in this talk to really go through all the mechanisms that obesity can contribute to chronic kidney disease, but I put this slide in here just to show that there are many different effects that obesity is postulated to have in the development of chronic.
Sorry, Lauren, can I just interrupt you for a sec?
Yeah.
Is Ben Lidgard talking in the room?
Oh, yes, I think.
Okay. Could you if you could pass along a message. It's just a little distracting. Ben, if you could step out, that would be great. All right, go ahead, Lauren.
Okay, so again, the slide is mostly to represent that there are many different ways that obesity is postulated to affect kidney function. It can cause afferent arterial dilation, efferent arterial constriction, and increasing the single nephron filtration. Again, there's many other stresses that contribute to podocyte injury and focal segmental glomerulosclerosis, as well as other conditions. But, I think the question is really, what can we do? And so, I'm very embarrassed to say that I graduated from medical school and residency, and I really only felt qualified to tell my patients that to lose weight, just try to eat a little less and exercise a little bit more. And I just don't think that is sufficient. So I was really excited when I had the opportunity to look at what our societies were recommending for how do we manage weight in patients with CKD. And so I found the 2020 nutrition and CKD guidelines from KDIGO, and KDOQI, excuse me, and I was very excited. And out of the 75 pages of recommendations, there are 0 that deal with weight management. So I was very lucky then to encounter this 2021 Cochrane review that was looking at different interventions for weight loss in patients with chronic kidney disease. You know, here I put the slide, and I know that the figures are a little bit small, but there's a couple points that I want to make from this review. And the first is, before I talk about the findings, I think we have to couch this in the idea that the evidence behind any of these interventions is pretty poor. That when you look at the grading of the different studies, there's a lot of concern about bias. Furthermore, these are really small studies. So again, I apologize that it may be so small, but you can see that the number of participants in any particular group is, you know, 10s, 20s, maybe 30s if you're lucky. And so again, it's very small studies. You know, the takeaway that, you know, from these points, so here on the left, you can see this is just lifestyle, so a hypocaloric diet versus not, and there is an association with weight loss. That's great. You know, what's interesting is that looking at physical activity and weight loss, that there was not strong data to suggest that physical activity, at least as measured in these trials, were associated with significant weight loss. And then I think what was really interesting to me was looking at the different types of diets, and that's what you see here on the right, which is a comparison of a low carbohydrate to a Mediterranean diet, low fat to Mediterranean, different levels of protein and weight loss diets. And what you really find is that no one diet is better than another. So where does this leave me? And I think, you know, I'm really not feeling confident in giving my patients, you know, firm guidelines or recommendations on any particular diet or activity that they should take. And instead, I really think that it's important for us to rely on our nutritionist colleagues. You know, I think some things that are harder to capture in a study, but I want to take a moment to recognize is that many of our patients with chronic kidney disease face many challenges to adopting either dietary changes because of restrictions they have, whether it's reducing protein or following a low phos or low potassium diet. And then furthermore, thinking about physical activity, if a patient is anemic or has symptoms of uremia and fatigue, it's going to be really hard to ask them to jump on a Peloton if they have one. And then finally, I do want to make the point that, you know, weight loss is not as simple as just as cutting calories. And that obesity is really a disorder of energy homeostasis, and the body may set a set fat point, which makes it hard for our patients to lose weight. And many of our patients, in fact, most of our patients, will likely not be successful in losing weight with just diet and exercise alone. So that might be a better pill to swallow. But it's time to talk about other medications and other pills that we could potentially use to help manage weight. So here I have a chart with 4 of the 5 FDA approved medications for weight loss. And you know, this is a great chart because it tells you the mechanism of weight loss. The orlistat is primarily through malabsorption. Phentermine-based medications are primarily through promoting anorexia and the stimulant effects, the bupropion and naltrexone, or the norepinephrine and dopamine. And you know, the issue with many of these medications is, so one, orlistat, although you know there's no issues as far as dose adjustment for chronic kidney disease, that it has some pretty unfortunate side effects, including fecal incontinence, and has reports of acute kidney injury and a concern for promoting oxalate nephropathy. You know, for these other medications, I really want to take notice that, you know, most of them are primarily excreted via the urine, and they are not recommended in patients who are on dialysis. You know, when thinking about patients who have CKD and whether or not these are great medications for them, I look at some of the other side effects, which include, you know, again, hypertension, renal tubular acidosis, uncontrolled hypertension. All of these things don't make me feel super great about giving this to my patients who have chronic kidney disease. So this brings us to one of our favorite new medications or class of medications, the GLP-1 agonists. And you know, if you haven't seen the grand rounds by Ian DeBoer earlier this year, I mean, I really recommend watching it. And I certainly won't get into the granular detail that he does, but this is to say that GLP-1 agonists are really hitting the field as one of the newer medications to promote weight loss. And this is a medication that many of us feel more comfortable using in our patients with chronic kidney disease. And we can see that GLP-1 agonists have a number of different effects across the body. And the ones that are most relevant for weight loss are really decrease in gastric emptying, and then promoting a sensation of satiety. So here's a list of almost all of the medications that are available in the GLP-1 receptor agonist classes here in the United States. And you can see that there is a number of different medications, that some of them are short acting, some of them are long acting. There are certain other things that you have to consider. So exenatide is a medication that they recommend avoid using in patients with a creatinine clearance of less than 30, as opposed to semaglutide and liraglutide are medications that are thought to be okay in patients who are on stage kidney disease. And so, there's some general class effects. So, certainly, there are side effects that we consider with these medications across the thing. But, I think the main point that I really took away from this is that, there are many different options, but they're not all the same. And so it's not as simple as just checking a box that a patient is on a GLP-1 agonist. And so this is a figure that really shows the change in the mean body weight in the different medications here. And these were based off of the clinical trials. And what you can see here is that, higher doses of semaglutide were associated, especially the subcutaneous forms, were associated with the most amount of weight loss compared to some of the other formulations. This does not include Wegovy, which is an even higher dose of semaglutide. So rather than it being 1 milligram, it's 2.4 milligrams weekly, and has an expected weight loss closer to 15% in the clinical trials. Obviously, this is nephrology. We love SGLT2 inhibitors. And so I think it's important to take a look at their role in weight loss. And, they are associated with a modest dose-dependent degree of weight loss, usually around 1.5 to 2 kilograms. And the mechanism is really great. It's very simple. Essentially, patients are peeing out the glucose. Unfortunately, the weight loss is not as much as you would expect, just because patients often have an increase in appetite and caloric intake. These medications do not have enough of a weight loss effect to be used independently, but they do have an additive effect, especially when used with other medications. So this was a really exciting presentation or report that I found just actually last Friday, which is that the FDA recently approved this new medication, the tirzepatide, which is a once weekly GLP medication that it was approved for type 2 diabetes. And there was the SURPASS-2 trial that was published in the New England Journal of Medicine last year, that was comparing semaglutide to tirzepatide, and showed that tirzepatide was associated with improved control of the hemoglobin A1C, as well as greater weight loss. The issue with that study, at least from our perspective, is that these patients that had a GFR less than 45 were excluded from this trial. And so again, is not necessarily encapsulating many of the patients that we see. There is, here you can see that they mentioned the SURMOUNT-1 trial. This is a trial that's looking at patients who do not have diabetes and looking at obesity management in this. And this is where they found that there is a 22.5% total body weight loss in that trial. They have not been published yet. When I looked at clinicaltrial.gov to look at the criteria to see who could be included in the study, that there was no exclusion criteria around chronic kidney disease. So it'll be very interesting to see who is included. Obviously, there are a lot of barriers to medication. So certainly there are side effects with the GLP-1 agonists. There are issues with GI side effects that make it hard to tolerate. And there's some real world studies that look at that. The other thing is these medications are expensive. So especially if you look at the cost of Wegovy, which is the higher dose of the semaglutide, the monthly cost of this medication is between $1,300 and $1,600 a month. And, unfortunately, insurance doesn't always cover these medications. And then, what I thought was very interesting, these are all very new medications. And the question I had is, do patients, if they stop taking these medications, do they gain the weight back? And unfortunately, it does look like there are observations that is one of the things that we see. So it's a question I have. So next comes bariatric surgery. And I like this picture because my question is, if bariatric surgery is so good, how come we're not recommending it, right? So when should we think about bariatric surgery? And these are just some guidelines of when patients may be appropriate. So you can see here, there are a number of different situations. So a BMI greater than 30 with diabetes, or certainly a BMI greater than 35 with an eligible comorbid condition. This includes, again, diabetes, hypertension, OSA, osteoarthritis, not CKD. And then, a BMI just greater than 40 without anything can be a qualification for bariatric surgery. There's a caveat I put here is that different programs and different insurances may have additional requirements for patients to get to undergo bariatric surgery. So what are our options? And here I have pictures of the 3 most common procedures that you guys may see. I grayed out the gastric banding because this is really a procedure that has fallen out of favor just due to it's got less weight loss and a lot more complications. But in the middle, you can see just a general picture of the sleeve gastrectomy, and then here on the right, a Roux-en-Y bypass. So, I think what was interesting to me is, I think I primarily thought about bariatric surgery as it being anatomic changes that, eventually cause the weight loss. But what's really interesting is that, these surgeries have more than just anatomic changes, but actually have changes in the different hormones that help regulate weight loss. And in particular, you can see here, there's increases in the GLP-1 levels in patients who are having Roux-en-Y bypass and sleeve gastrectomy. And the case in point that I make with this is that patients who have bariatric surgery who come on multiple medications for their diabetes or hypertension, that when they leave the hospital after their surgery, before they've lost any significant amount of weight, they may already be in the point where they've greatly reduced their insulin requirements or their blood pressure medication requirements. So again, this is more of a hormone-mediated process than we appreciate. So, next, this is just a picture that represents the expected weight loss after bariatric surgery. So here you have the gastric band, which has the least. You have a sleeve gastrectomy, which again looks like an expected total body weight loss is expected to be around 20-25%. And then with the Roux-en-Y, it's closer to 30-35%. You can see over time that people do gain a little bit of weight back. So, we've talked a lot about, what to expect from bariatric surgery, but the question, of course, is, does bariatric surgery help patients with chronic kidney disease? And this was a very interesting study that I saw that compared 760 patients who had bariatric surgery versus a control group of around 760 patients, and just at their time looked at, what the proportion of patients who had, decline in their GFR greater than 30%, or what, really matters to us, which is, doubling of serum creatinine and development of end-stage kidney disease. And what you see here that's really striking is this separation between patients who had surgery and patients who did not. Obviously, there's some caveats being that these are not randomized controlled trial, and whether there's a difference between the patients who had surgery and not is an important consideration. So this is a study that was actually just published this week that Dr. Eng brought to my attention. I'm very thankful for. But this was a retrospective single center cohort study out of the Mayo Rochester Clinic, where they looked at 43 patients who otherwise would have qualified for kidney transplant except for their BMI. And they looked at patients who went to a weight loss clinic and compared those who underwent medical weight loss versus those who got bariatric surgery weight loss. And what you can see here on the left is that patients who did not have surgery really did not, for the most part, have significant weight losses over the follow-up period. Those who had bariatric surgery had pretty significant weight loss, and many of them actually lost enough weight to qualify for bariatric surgery. And I think the real striking point here is that patients who underwent bariatric surgeries were 8 times more likely to get a transplant than those who didn't. And yes, there are still issues with the study because it was not, a randomized controlled trial. We don't know why patients got bariatric surgery and why some patients chose medical management. But I think this is striking enough to make me wonder, should we be doing more to advocate for our patients to get bariatric surgery so they can qualify for transplant? It would not be fair for me to talk about bariatric surgery without recognizing the risks. Certainly, there are immediate postoperative risks. The risk of AKI during bariatric surgery is quoted to be around 3 to 9%. There's obviously surgical complications, or longer-term complications such as malabsorption and vitamin deficiencies. Obviously, in a malabsorptive process like a Roux-en-Y bypass, you could have an increased risk of oxalate nephropathy. This was a study that looked at 400,000 patients that had bariatric surgery in Michigan and basically compared patients with end-stage kidney disease in the green, which represented about 0.3% of those patients versus those who had no kidney disease. And you can see overall that there is a higher risk of complications in patients who are end-stage kidney disease. But again, the absolute difference is you're not huge. And I think it's, overall a relatively safe procedure. What are the issues with bariatric surgery? Well, unfortunately, a lot of our patients can't get it. And there's multiple reasons for that. Some of it is they may not qualify because of medical comorbidities or psychiatric comorbidities that preclude them from transplant. And those are things that we may not be able to change. However, many of our patients don't get bariatric surgery because they're not referred or because their insurance doesn't cover it. And I think those are the areas in which we can really advocate for our patients and really try to get them the care that I think that they may benefit from, at least some of them more. So with that, I hope that you guys can take away that obesity is a problem that many of our patients face, that unfortunately the data behind lifestyle interventions, including diet and physical activity, is limited, although I'll still continue to recommend it. There are a lot of promising new medications that I think offer a lot of opportunities, but still have a lot of questions. And bariatric surgery may be appropriate for some of our folks. And the long takeaway is really, we need more research. So hopefully some of you guys can really help answer these questions. With that, I will take your guys' questions.
Wonderful. Thanks so much, Lauren. Questions for Lauren? I see one in the chat. Kate, if you're on, you want to just ask your question?
Sure. Really nice talk, Lauren. Thanks. I was wondering, I'm hearing a lot about making a distinction between exercise, like, jumping on a Peloton, like you say, which can be probably a little bit intimidating for some of our patients and for some of us, and physical activity, like just being more active during the day, and sedentary time as totally separate kind of things to measure, and physiology might be different. Do you know anything about how those might impact weight loss differently?
Yeah, I think that's a good question. I'm not as familiar. Largely I was looking for evidence in our chronic kidney disease patients, and certainly I will promise you that is something that has not been studied in patients with kidney disease. But that's a great question.
Oh, thank you.
Nisha?
Thanks, Matt. Lauren, fabulous talk, really excellent work in putting together a very complex topic. My question gets around the idea of weight, which is complicated in patients with kidney disease. Does weight, BMI, reflect body composition? And how do we consider that when we think about these therapies and options for our patients?
Yeah, Nisha, that's an excellent point. If I had another hour to talk, I could really hammer into this. So, you're exactly right. The BMI is not always a great measurement for our patients. So what I always think about is, the patients that we diurese in the hospital, 30 pounds, I wonder if I should go home to my husband and tell him he's worthless. Kidding. But no, there's some suggestion that, waist circumference may be a better measurement in patients with chronic kidney disease. They actually did a comparison looking at patients who had an elevated BMI and looked at like the percent body fat that would qualify them for obesity. And actually more patients even who had lower BMIs that we may not consider obese would actually qualify based off body fat. So I think more of our patients are at risk for these metabolic complications than we understand.
Thank you.
Raj?
Lauren, fantastic talk. You did an amazing job. Thank you for that. I have to say, for my people on dialysis, I have an ambivalent relationship with regards to my advice for weight. There are all of these epi studies that show people that are larger live longer. And the way I view it when I talk to my patients is that, hey, if you have a chronic disease and you're well enough to eat so that you can gain weight, I actually celebrate that. That's a sign of health. The people that are struggling with health are the ones that lose weight. The only reason I want them to lose weight is because of transplant.
Yeah.
And had it not been for transplant, I would just kind of let them be.
Yeah.
So what are your thoughts on that regard?
Yeah, so I think that's a great point. So, I think what you're describing is the obesity paradox that we see in many conditions, but certainly in patients with kidney disease as well, where, obesity may be associated with better long-term outcomes. I think the difference is that, I don't think it's necessarily a fair comparison, because I think that patients who are losing weight unintentionally may represent a sicker population. And I still wonder, and I think we need studies in this, if even the patients that we think are doing well, that are eating well, that maybe have a higher BMI, I wonder if they may still have benefit from losing weight.
Maybe last question from Nikolai here in the chat. So he asks, can you comment on the data showing potential improvement in GFR with weight loss, especially after bariatric surgery in CKD?
Yeah, I think that's a great point. So I think there have been studies, and again, there's not enough time to review all of that here, but there are some suggestion of improvement in GFR after bariatric surgery or after a certain weight loss. I think it becomes a little bit harder to measure, because we have to recognize that when patients undergo bariatric surgery, they may lose weight, including muscle mass, that make especially creatinine-based measurements of GFR more complicated to interpret. But I there is data, especially when they use more cystatin-based measurements of GFR, that do show some benefit.
All right. Well, thanks so much, Lauren. I know there may be some of us who will be asking for copies of your slides. So great work. We'll move on now